Hi everybody, I'm very pleased and honored to take part at this great 25th anniversary of the Egyptian Vascular Club. The club did a lot for the expansion of vascular surgery in Egypt and all the region, and you can be very proud of this. So I was there at the beginning and you still think about me, and I'm very honored by this, and I would like to thank the organizing committee to give me the opportunity today to talk about management of a very specific entity, the aortic free floating thrombus. So I don't have any disclosures. Aortic free floating thrombus without aneurysm or dissection is rare. Mostly completely asymptomatic floating thrombus has a high risk of embolization. The treatment is mandatory, but there's still no consensus about how to treat this. Nowadays, endovascular treatment is becoming the first choice. So, what are the issues? We are in front of three important questions. First, the location of the thrombus. Is this in the ascending, in the arch, or in the descending aorta? And this with the difference in the treatment. The second is the diagnosis of the mass etiology. Is this a thrombus or something else? An angiosarcoma or something like this. And finally, what should we do in front of this thrombus and how we should treat it? Floating thrombus is a very uncommon disease, mostly asymptomatic. That's why the early diagnosis is often difficult. And the pathophysiological mechanism of this thrombus is still unclear. Why is the FFT such a difficult problem? Because of the potential risk of distal embolic events that can be sometimes catastrophic or even lethal if we go in the cerebral and the coronary arteries. How should we explore the patients to confirm the diagnosis? First of all, we should search for hypercoagulation state. Then, to better explore the thrombus, we use echocardiography, angio-CT scan, or sometimes angio-MRI. The location is very important, mostly located in the isthmus or on the below aorta. The rest, but more dangerous locations, are the ascending aorta, because you can have an embolization through the brain. Transesophageal echocardiography is a valid tool to evaluate the aorta, the supraortic trunks, and the pulmonary arteries. Like on this slide, you can see a potential embolic mass with a 1 millimeter base and high embolic potential. The mid and distal aortic arch is sometimes poorly visualized on TEE, so that's why we have to use other specific procedures, and the angio-CT scan is the most important thing for this. And as you can see on this slide, it's a very huge floating thrombus in the ascending aorta, and this patient had a stroke. This is another image of an ascending aorta free floating thrombus, descending thoracic aorta with a splenic infarct. Small bowel ischemia by occlusion of superior mesenteric arteries. Okay, as you can see, the potential risk of embolization is everywhere. And finally, this is a very rare image. It's not my image, it's by colleagues from our Belgian friends, and you can see FFT in the ascending aorta with an unexpected outcome, with an acute coronary syndrome by embolization of the coronary arteries. So, do we have any index to predict the clinical evolution and the embolic potential of these free floating thrombi? How can we embrace the risk of a major surgical operation? The Polish and his team have defined a new parameter called the break of risk ratio, or BOR, referring to the length ratio of the floating and the attached portion of the lesion, and a high value as a greater potential of breaking off. So you can when we have a sessile one, it's at 12%, pediculated is 73%, so pediculated are a higher risk of embolization. The location is another important point, and more proximal lesions are, and more the risk is high. Intraluminal floating thrombus or aortic in-stent thrombus are the most dangerous. And Himanshu worked on an interesting topographic and morphological classification published in 2014 in GVS, and I invite you to read it with more precise interest. What are the treatment options? So there's no consensus on therapeutic recommendations, and if you look at the literature, you can see that a conservative approach with anticoagulation, open surgery, and endovascular interventions were all reasonable treatment options depending on the size, location, mobility, and clinical expression of the thrombus. The endovascular or hybrid approach is nowadays it's becoming more and more the first choice. So the conservative approach by medical treatment of antithrombotic therapy in aortic disease, it can be used for asymptomatic patients, for small sessile thrombi, and for aortic in-stent floating thrombus, which is a quite difficult problem to deal with a new endovascular procedure. Like in this case published by Yang in 2017, you can see the angiogram with a huge thrombus on the T-bar. The surgical approach. The surgical approach depends on where you are. So first on the ascending aorta, you can see open surgery for ascending aorta thrombus. It's a courtesy by DMAT, published in cardiovascular thoracic surgery. You see the big thrombus on the aortic root. The aortic arch, even there it's quite difficult to go by open surgery. Here you can see what they told of the aorta. The descending aorta is a little bit less difficult, but it depends of how big the thrombus is. And here they have a very big thrombus, and you see what we had on postoperative. Endovascular hybrid approach is becoming more and more the first choice for descending aorta, and even for the arch, and even now sometimes for ascending aorta. Personally, we treated 8 patients by this technique with excellent results. The arch can be treated by a hybrid approach, like in this case, the supra-aortic debranching and anterograde allograft implantation. The descending thoracic aorta, you just put a stent in it and you crush all the thrombus on the aortic wall. What are the new tools? Those are new tools, first described by Thilo Kolbel in 2017 and the Hamburger team in 2018, the use of vacuum-assisted percutaneous thrombectomy using the AngioVac system is nowadays a new option for patients unsuitable for open or endovascular repair. As you can see, there are a lot of publications about it, but there are small case reports. But it seems to work, and as you can see, it was being used mostly in the descending aorta, but even in the ascending aorta, where other options can be very challenging. But we still need more experience to confirm the future of this new tool. And here you see the system, how it can be used, and the aspirate thrombus and the AngioVac system. So what are the take-home messages? First of all, there are still no clear guidelines on this. When you look at the European Society of Cardiology guidelines in 2014, the most important guideline is it's a team decision. It depends on what you have, what you can do in your team, and then you have to choose. We propose this algorithm to treat our patients apart from suspected tumoral disease and ascending aortas, always treated by open surgery. For the other case, medical and endovascular approaches nowadays are first option for all other cases. Patients with uncommon aortic disease, such as the reported free-floating thrombus, should be treated by individualized interdisciplinary approach. Besides the recommended treatment options, there are other uncommon approaches that might offer an alternative in complex case, such as the vacuum procedure. Thank you for your attention.